Knowledge translation. I'm sure that any one of you is triggered by that question. How do we do this? How can we make sure that research findings find their way better to our clinic? And indeed, there are several stakeholders in this matter. First stakeholder are the researchers. Other stakeholders are the clinicians. And it should not be the case, but it is often so that researchers and clinicians are living in different worlds, have different objectives, have different deliverables, and therefore they live in different realities. For instance, a question, a thought that researchers may have is, I found these brilliant study results, why don't they implement it? It's so easy, just do it. And the clinician, on the other hand, and I'm sure many of you recognize this, it's okay, sounds nice in theory, but I'm really dealing with other problems here in practice. And realizing that these are two different worlds, it's clear that we need something, someone, to bridge this gap. And this is where knowledge translation comes into play. Just to know, as a background, is if you look at studies that address the gap between realizing or finishing or publishing a study and implementing these data in day-to-day practice, a study looking at nursing research studies found that this gap between the knowledge and the doing is 10 to 15 years. Another study also looking at nurse research, they found 8 to 30 years. A study looking at medical studies, on average 17 years. So it is indeed a huge gap. We are losing time with this. Of course, the first question, and we need to be critical, true. First question is, but why should we worry? Is this really a big problem, or is this a problem that there is a gap? Well, if you look at all the care that is provided today by nurses, we can see, based on empirical data, that 30 to 40% is not according to the evidence. This is a lot. On the other hand, 20 to 25% is unnecessary or harmful. So this means that only 1/3 of the care that is provided is appropriate. Yes, this is a problem because we are spending a lot of time, a lot of effort with all good intentions, that's true, but we are losing our time and we are kind of throwing away the potential impact that we have. So the question should not be, why should we be concerned? The question is, what if we don't? If we don't do that, 1/3 of what we do makes sense and the rest doesn't make sense. And then indeed, knowledge translation comes into play. Knowledge translation, it's a broad term that pertains to how you really can have an impact on day-to-day practice based on the research. And a definition of knowledge translation, or at least the aim of knowledge translation, is to enhance the use and usefulness of research. It covers the design and conduct of studies as well as the dissemination and implementation of findings. It's clear it is a container concept. It's very broad, different aspects belong to that. And you can follow courses on knowledge translation because it is so broad and it is so widespread. For the sake of time, for this presentation, I would like to address three different elements, three aspects that pertain to the knowledge translation, which is evidence-based practice, implementation science, and the maturity of the system. Evidence-based practice. This is David Sackett, and he is the founding father of evidence-based medicine. And he defined evidence-based medicine as the integration of best research evidence with clinical experiences and patient values. And this is a very helpful definition. And to a certain extent, you could kind of blur the medicine word in this and replace it by practice. Because it is true for all the care that is provided, evidence-based practice, evidence-based healthcare is the integration of what is discussed here. So indeed, if we look at evidence-based practice, there are these three elements: the external evidence, the clinical expertise, and the patient values. And therefore, the stakeholders are there. The problem, however, if you ask me, no, I will keep that for the next slide. Because when you are asked how you can provide evidence-based practice, there are a few steps to follow. You as a clinician, you can follow these 5 steps. First, ask, and that refers to formulate an answerable clinical question. Second, you as clinician have to access, track down the best evidence. Third, you as clinician have to appraise the evidence for its validity and the usefulness. 4, apply, and that refers to integrate the results with your clinical expertise and your patient values and local conditions. And finally, 5, you as a clinician have to evaluate the effectiveness of the process. That is what I wanted to say. The responsibility is put with the clinician. And although I'm a strong believer of evidence-based practice, I also see the barriers here. If all the responsibilities are put on the shoulders of the clinicians, it's difficult. And you all know that there are sometimes situations, circumstances where you say, I would like to implement this, but I'm just not in the environment that supports me to do so. And then it's implementation science that comes into play. Because when we move from evidence-based practice and we try to get a bit broader perspective, we come to implementation science. And implementation science, it is not just implementation. That is a question that I sometimes get. It's like, okay, but just implement it. Yeah, that's the researcher's perspective. Implementation science refers to the methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence to improve the quality and effectiveness of the health services and care. In implementation science, they are not only looking at, is it effective? Does it work? Is it worthwhile to do so? But they also look at, what does it take to implement this? Are the environmental factors available there? And it is nicely expressed in this cartoon. There are more stakeholders in implementation science than in other research. For instance, you have the researcher, the one in the very first slide that I showed you, looking for evidence-informed interventions. Second, you have the clinician, the implementer, who is requested, who is asked to implement these findings into day-to-day practice, but need to bear in mind that there is a local context. third, you have the policymakers, the management, the administration that decides in many ways if and how you can implement certain aspects. And that is where the implementation scientists come into play. Try to get a view on the different aspects here, not only on the effectiveness, also on the local context and also on what policies are needed. Policies at different levels. Micro level, does my nurse manager support me? Is the time given? Do I have the room to do so? And so on. Also the hospital administration, but it also can go to the macro level. Is the healthcare system allowing me to do so? And yes, implementation science has a place in knowledge translation. And this is a very nice opinion paper published in BMC Medicine. By the way, these authors are editors of the journal Implementation Science. So there is a dedicated journal towards implementation science. If you are interested in learning more about implementation science and maybe even conduct implementation science studies, know that it is of critical importance to base or to rely on frameworks. There are different frameworks that really can guide you through an implementation study. This is just one framework, the Consolidated Framework for Implementation Research. And this framework indicates that there are 5 elements. On one hand, adapting the intervention to the local setting. For instance, if Eva-Lena was this morning referring to the Stepstones project, which was developed and implemented in Sweden, she also referred to the implementation study, which means that a study that is done in these 7 centers is not necessarily transferable to other centers in Sweden, not to speak about the United States or Canada or Belgium or whatever. So you have to adapt the intervention to the local situation, not only national, also sometimes your particular hospital and ward. Addressing the inner setting, addressing the outer setting, working with individuals who are involved in the intervention and in the implementation process. That's when you have to involve your managers, because they decide if the clinicians can get the time to do something or not. And optimizing the process of implementation. And that is a nice illustration, a nice visualization of these different elements that are relevant in an implementation science study. You have to know that it is not so that there are specific designs developed for implementation science. Descriptive designs, qualitative designs, all can be used in implementation science. But sometimes the combination makes it very relevant and very unique for an implementation science study. For instance, there are these so-called hybrid research designs. A hybrid type 1 design in the context of implementation science. For instance, this is a design where the primary aim is to look at the effectiveness of a clinical intervention. And the secondary aim, so while you are doing the effectiveness trial, you are also looking at what is the context, what makes it possible, and so on. So the implementation aspects are embedded in the trial. Go to the other side of the spectrum, a hybrid type 3. There the primary aim is to look at the implementation strategies. What works? Do we need to facilitate the implementer? Do we need to work with the administrators, with the managers? Is it just a matter of more time, or is more entailed? This is primary aim implementation. The secondary aim can be the effectiveness. We know that it worked in that randomized controlled trial. Now we are implementing, we are testing different implementation strategies, And at the same time, we also would say, what effect is it having on the patient? And type 2 is in between, which means where the effectiveness and the implementation strategy is as important. What is the situation in congenital heart disease? So before I traveled here, I looked at PubMed, entered congenital heart and implementation science, 13 hits. I thought, yes, something is happening. Then I looked through it and none of them are implementation science studies. These are articles that refer to implementation science is needed for further development and so on, but they didn't do it yet. But I'm hopeful. And I would like to build up on what Eva-Lena this morning referred to when she was presenting the effectiveness data on Stepstone's transition program. And also the qualitative studies that we did. We looked at implementation fidelity, which clearly is like, which are the factors that were implemented as it should be and which are not, and what are the mechanisms of impact. And that is really informing the Stepstones implement, where the goal is to implement an effective and sustainable person-centered transition program for young people with long-term conditions in Sweden. The third element, very briefly, is the B3 maturity model. This is a model that looks at systems. How mature is a system for change? Is the system, the healthcare system, and that can be seen at the national level or at the state level, is this healthcare system ready for change? And then you have to look at what about readiness? What about the structure and governance? What about finance? What about population approach, citizen empowerment, and so on? So this maturity model, this B3 maturity model, is really a good framework that helps you to really look upon it from a helicopter perspective and see the system. How much is this supporting what we have to do? Let me come to the conclusions. The knowledge-do gap has to be bridged. There are different ways for knowledge translation, and I only addressed 3 of them. Knowledge translation does not require specific research designs. However, the hybrid effectiveness implementation designs can indeed be useful. And system factors also need to be incorporated. It is not the sole responsibility of the clinician to make it happening. It's the system and the management and the administration that also need to support it. Thank you very much.